So hi everyone, good evening. Thank you so much for joining this evening's event on Dying Well, Palliative Care and the Psychedelic State. My name's Gemma Knight. I'm one of the lead therapists working on clinical trials with psilocybin at King's College London. I'm a clinical psychologist and I have worked in the NHS in older adult services supporting people who live in care homes. So I have experience of working with people nearing the end of their life. So I wanted to organise this event as it feels really important to explore the ways that psychedelic assisted therapy can help support people in palliative care. This is an area of great interest, so I'm really excited to welcome you all to this long anticipated event. We've got just a couple of house rules just for the evening, which have also been emailed to you all. We ask everyone to please keep your microphones muted throughout the event, just until it's your turn to speak. There will be a few minutes at the end of each talk for questions, as well as during the panel discussion at the end after our break. So please, can you use the function to raise your hand to ask a question, or you can just type it into the chat and we will come to you. So I'm very pleased to now introduce our evening's chair, Professor Matthew Hotoff, the Vice Dean of Research at the Institute of Psychiatry, Psychology and Neuroscience at King's, who will now introduce our speakers for the evening. Thank you so much. I hope you enjoy.
So thanks very much, Gemma, and thank you for inviting me to chair this exciting event. My name is Matthew Hotoff. I'm a psychiatrist by background, and I wear a number of hats. One of them is as director of the National Institute of Health Research Biomedical Research Centre at the Maudsley. That's a big mouthful, but the BRC, as we call it, is responsible for trying to develop new innovations in therapies for a range of disorders, including most mental health disorders and some neurological disorders. We're very excited by the work which is being led by James Rucker and others in this group on the development of psychedelics as a potential therapy in a range of psychiatric disorders, particularly in things like treatment-resistant depression. So it's something which I've been sort of observing from the outside with some interest, and I'm very keen to learn more today. I'm also a psychiatrist who sees patients, believe it or not, and I actually work in a hospice. So for the last 20 years or so, I've been working at St. Christopher's Hospice, which was really the first hospice the first modern hospice, and where the sort of palliative care movement to a large extent started, certainly in this country, led by Cicely Saunders. And the work I do there is a wonderful break from a lot of the kind of research admin I do at the other end of my job, because you're seeing people with very diverse and interesting histories who are all facing the inevitable of death themselves, and sometimes facing a relative's death. So we see people who are bereaved as well as the people who have experienced are close to death themselves. And in a sense, you see all of psychiatry through this prism of an extreme and extraordinary point in someone's life. And my job very often is to see people because the clinical team are worried about them having some sort of mental health problem. And quite often my job is actually to suggest that they don't have a mental health problem. They are simply dealing with this extraordinary existential threat. And in some situations, I do diagnose and treat often problems like depression and anxiety and so on. And it's interesting now to sort of think about the use of psychedelics in this field of palliative care. There are challenges. I think there might be all sorts of reasonable skepticism and reasons why people might question their use. One issue I think is really important is that, you know, some of the clinical work I do, I'm seeing people where there's been a sort of diagnostic issue, really, and quite often you see people who are very ill physically. They have all sorts of reasons why their thought processes might not be as straight, and some of those are very directly kind of physical reasons because of an imbalance in metabolic and a metabolite or something like that. So a lot of my work is actually to try and identify those sorts of problems which require a different solution. So it'll be very interesting when we've got the panel discussion at the end with some of the sort of insights from other colleagues in palliative care and maybe people in the audience about what some of the challenges might be. But I think at the same time, one needs to start this with an open-mindedness. And I think what I was reminded of, actually, just thinking about this, was when I first started in palliative care, I was hauled before, well, not hauled, I was invited to speak to Cicely Saunders, Dame Cicely, as she then was, who was retired from clinical practice, but still very much present, and you know, a very formidable presence. And she spoke about the way in which, you know, in the time when the palliative care movement was first starting, the introduction of opiates for pain was highly controversial. This was something which was considered to be, you know, a really rather dangerous thing to be doing. And quite a lot of the early work of palliative care was establishing that that opiates, and sometimes, you know, very strong opiates, we prescribe diamorphine or heroin in these settings, is not only a reasonable thing to do, but an absolutely critical thing to do. But that came about with careful evaluation and a balance of risks and benefits and so on. So I think, you know, one of the things we are committed to as an organisation at King's College London, IOPPN, Institute of Psychiatry, Psychology, Neuroscience, is that kind of careful evaluation of new treatments. But at the same time, I think it's very helpful because we've got a fantastically diverse set of speakers to come today, and it's my pleasure to introduce them. Now, of course, I'm paperless, so I'm dealing with another computer screen, which is why you see me lurching off there. So I'm going to invite the first speaker to present, and this is Dr. Sam Gandhi, based at Imperial College London, who has a fascinating CV with a background in ecological science from the University of Aberdeen, but now working a great deal in the Centre for Psychedelic Research at Imperial College London. Sam is going to talk about a trip beyond existential fear, the history and science of psychedelics and end of life.
Thank you, Matthew. Yeah, it's wonderful to be kicking off this great event. I'm just gonna play my. There we go. So yeah, I just thought through this talk, I'd hope to sort of bring everyone up to speed on sort of the history and the science of this area, of the intersection of psychedelics and end of life care. So yeah, there's been a few different substances researched over the years in this context. So psilocybin, LSD, and DPT, or dipropyltryptamine. But the bulk of modern research has been with psilocybin. And psilocybin and this family of compounds are classical psychedelics. And they are known for being non-toxic, relatively non-toxic, physiologically well tolerated and non-addictive, but they exert profound and powerful effects on the human psyche. And it's also worth noting that psilocybin has a long history of usage as an agent in both healing and divination. We don't die well. in the West. And I would say actually, as medical science has advanced, if anything, we've regressed in terms of how we approach and perceive death and dying. Medical science really has advanced and is amazing at keeping us alive, but it's much sort of more poorly equipped to sort of assist us in dying and preparing us for dying. It doesn't have to be this way, however. We can definitely approach death and dying from a very different context. And just going to move those little boxes. So yeah, and I thought this is an interesting perspective from Stan Grof pertaining to this sort of alternative perspective one might have. Dying before dying influences deeply the quality of life and the basic strategy of existence. It reduces irrational drives and increases the ability to live in the present and to enjoy simple life activities. Another important consequence is a radical opening to spirituality of a universal and non-dominational type. So some people may be aware of the Wassons, R. Gordon Wasson and his wife Valentina, two sort of amateur mycologists. They were sort of allowed to experience a velada, a mushroom ceremony with the Mazatec shaman Maria Sabina. And that was in the middle of 1955. And in 1957, she gave an interview for This Week magazine. And she stated that, among other things, she felt psilocybin could have great potential in treating terminal illness. So this is interesting because from the very first psilocybin experience ever experienced by a Westerner, this potential was recognized. Aldous Huxley was also a big proponent of using psychedelics to assist people in their dying. And here he's in conversation with Dr. Humphrey Osmond, who's the psychiatrist who first coined the term psychedelic, and he felt that LSD could help make dying a less physiological, more spiritual process, and that we should be doing more to assist our dying. Huxley didn't just talk the talk, he kind of walked the walk as well. And on his deathbed, as he lay dying of laryngeal cancer, he motioned to his wife to inject him with LSD, which she did, and 2 separate 100 microgram doses. And his wife Laura said that he died the most serene, the most beautiful death. Stanislav Grof sort of kept the lantern burning and did some research at the Maryland Psychiatric Institute with terminal cancer patients using primarily LSD and some DPT. And yeah, an interesting thing to note is that some of the terminal cancer patients that had psychedelic therapy, as their cancer advanced and they came closer to death, some of them had classic near-death experiences. And these people remark how similar the states of consciousness were between their psychedelic session and the near-death experience, and that the psychedelic session was a really good experiential training for the dying process. So yeah, just to quickly go over some of the research that's been done. So Charles Grobe at UCLA sort of kicked things off with a phase 1 proof of concept study to see whether psilocybin could be safely administered to terminal cancer patients and whether it was promising enough to sort of like research further. And it was found to be so. So it seemed it was safe, physiologically, psychologically, no adverse events, and evidence of enduring benefits. Peter Gasser did a study in Switzerland, this time looking at LSD. And again, yeah, no lasting adverse reactions and long-term benefits. So a year after sort of the dosing session, people were still feeling psychological benefits. And yeah, these large-scale reductions in anxiety and quality of life. And it's interesting to note during the sessions themselves, they could very much promote anxiety and bring up anxiety and be challenging psychologically. But in the right setting, handled with the right therapist, these experiences can be cathartic and beneficial. So yeah, there's some phase 2 studies, rigorous double-blind phase 2 studies conducted by Johns Hopkins and then NYU. And yeah, the results of studies, while also being very vigorous, the results themselves were very impressive. So 80% of participants on these trials reported lower depression and anxiety at 6 months follow-up, along with reduced death anxiety. At the same time, increased quality of life, life meaning, and optimism. And yeah, over 80% of participants endorsed greater well-being and life satisfaction as well. And it was, the mystical type experiences that psilocybin can occasion. That was a key mediator of the long-term therapeutic outcomes. So this was an independent study conducted around the same time at NYU, and interesting to note, reported remarkably consistent results. So again, 60 to 80% of participants showing clinically significant reductions in depression and anxiety, immediate, substantial, and sustained improvements in anxiety and depression, and decreases in cancer-related demoralization and hopelessness. And again, the mystical experience was found to be a key mediator of long-term therapeutic outcomes. So this is an interesting long-term follow-up of some of the NYU study participants. So 3 and 4.5 years after the NYU study, 15 of the 16 surviving participants were again assessed. And yeah, so things like depression, anxiety, hopelessness, demoralization, and death anxiety were still significantly reduced at both points. And after all this time, and participants also attributed numerous positive life changes following this experience. So yeah, it's important to emphasize this is these are still sort of small studies in the grand scheme of things, but this is an unprecedented finding in the field of psychiatry, that a single dose of a substance administered in a supportive setting can produce effects almost half a decade later. There's nothing else that comes close to this. And just to summarize all those studies, so to put them in the context of the wider psychedelic research field. So yeah, these are rigorous studies in terms of their placebo-controlled, total of 92 participants, compared to sort of the smaller open label studies that have been done so far on things like depression, smoking cessation, alcoholism. And yeah, a large effect size. So some of the strongest, most impressive results yet obtained in the field. So at 6-month follow-up, 78% on average of people having sort of clinical benefit, like reduced depression, whereas about 31% in the depression studies, major depression studies that have been conducted so far. So over double as effective for existential anxiety. There's obviously a clear unmet need for more treatments and therapies here. So existing treatments for palliative care for end of life, psychotherapy and drug treatments, the latter in particular may come with side effects. People who are terminally ill are more at risk from disequilibrium and falls, polydrug interactions. And so this psychedelic therapy offers a sort of way around that. There's an ongoing trial being conducted at St. Vincent's Hospital in Melbourne, which is the first psychedelic trial ever conducted in Australia. It has been paused due to COVID. It's important to note that existential anxiety is something distinct from depression. It's closer to demoralization. And that's important because the DSM-5, which is kind of like the psychiatric diagnostic textbook, if you will, does not recognize terminal or, well, existential anxiety or angst as a standalone condition. Right now, it's considered a subtype of depression. And this is important because if it was a recognized standalone condition, which it should be, it probably would have been granted breakthrough therapy status by now due to the strength of the evidence. It's also interesting to note that that psilocybin can also elicit sustained increases in death transcendence, the feeling that life in some form goes on post physical demise, and this occurs in clinically healthy volunteers. So this is important because psychedelics are very much context dependent, but it hints that this is an intrinsic part of the psilocybin experience or the mystical experience that psilocybin can occasion. So just to kind of get across the power of these experiences, there's a few accounts from some of the trials that have been done so far. I'll just read. I felt like I was being shown what happens after death, like an afterlife. I'm not a religious person, and I'd be hard pushed to say I was anything near spiritual either, but I felt like I'd experienced some of that and experienced the feeling of an afterlife, like a preview almost. And I felt totally calm, totally relaxed, totally at peace, so that when that time comes for me, I will have no fear of it at all. I now have the distinct sense that there's so much more, so many different states of being. I have the sense that death is not the end, but just part of a process, a way of moving into a different sphere, a different way of being. I felt like I was bathed in God's love. I'm still an atheist, by the way, but that really seemed to be the only way to describe it. So what these accounts get across is this is a deeply affecting and transformative experience. One's prior spiritual or religious beliefs, or more importantly, lack of them, don't make any difference in terms of the transformative potential of this experience. And just a few views of some of the sort of psychedelic researchers in the field. So David Nichols says, if it gives them peace, if it helps them to die peacefully with their friends and their family at their side, I don't care if it's real or an illusion. And so, yeah, the enhanced spirituality that can sort of result from the mystical experiences under psychedelics like psilocybin can allow people to sort of feel this sense of connectedness to the sacred or something bigger than themselves, enhance loving relationships with family and loved ones, and live fully in the moment with equanimity and acceptance. So I just wanted to share the view of Dr. Anthony P. Bossis of NYU, because he's one of the very few people in the psychedelic field who's also an expert in palliative care. So his view sort of, I think, is quite interesting and informative. While there have been advances in chemotherapies and pain management, there remains a paucity of therapies to address and relieve the emotional anguish experienced by the dying. The psychedelic therapy model represents a potential paradigm shift for the future of hospice and palliative care, providing a novel and effective therapy to relieve the emotional and spiritual distress so often experienced at the end of life. Not only can it offer emotional and spiritual healing for those facing their mortality, but it can also help their families who witness the release of suffering in their loved one. And this is an important point in that having this sort of different approach, this psychedelically assisted approach to death and dying, it doesn't just impact the person in question, the person who's dying. Like this also affects their immediate family circle and loved ones. So this is a recent development, kind of history being made really, but 4 terminally ill Canadians were granted exemption, legal exemption, and allowed access to psilocybin. And I think there's now sort of discourse going on in Canada for the government to sort of do a broader approval for psilocybin and its use in end of life. So that's a great achievement, and hopefully will help set things in motion elsewhere. So this is an article I collaborated on, so with Ivor Williams, who's speaking next, and Rosanna Ellis, who's also part of this event. And yeah, just to sort of say that this information exists in a sort of amalgamated form in the form of this article, in case this might be useful or of interest. So yeah, looking ahead a little bit more, we know from the research conducted in the past that psychedelic therapy can result in a sustained reduction or need for pain medication, which is interesting. So an extra sort of add-on will be to look at kind of cancer-related pain, as well as the existential aspects. And then, of course, while all the research so far has been with terminally ill cancer patients, there's other terminal illnesses, such as neurodegenerative diseases, that might also be worthwhile to look at. And hopefully, who knows, after the phase 3 trials, we could have sort of psychedelic hospices where, you know, there'll be sensitively constructed settings and have experienced psychedelic guides there on hand. There may even be the potential for shared partner or family group sessions. I mean, this is maybe looking ahead a bit more. And then, yeah, in palliative care staff themselves who experience a lot of emotional burnout from the work they do. Psychedelic therapy could also be useful for them. So, yeah, that sort of kind of wraps it up. And just to end on this quote that sort of highlights, yeah, a new perspective and approach to dying that we could have should we go down that path. To civilize death, to bring it home and make it no longer a source of dread, is one of the great challenges of the age. Gradually, dying may come to hold again the place it used to occupy in the midst of life. Not of terror, but a mystery so deep that man would no more wish to cheat himself of it than to cheat himself of life. Thank you.
Thank you very much, Sam. Fascinating presentation. So we can't have a round of applause, though I see you can have an emoji of a round of applause. Someone had it up. But thank you very much. So we've got a little bit of time now for questions and comments. I don't know if anyone would like to start us off. This is one of the well, whilst we're waiting for other people to collect their thoughts, I mean, I guess the question I have, I suppose I was hinting at in my introductory comments, was really around, you know, weighing risks and harms against benefits, and you've emphasized the benefits. I'm not familiar with those clinical trials, and they look well conducted and all the rest of it. Were there adverse events reported? Because I suppose, you know, sorry to interrupt, but I suppose, you know, the fear in the back of my mind is what happens with if you have a really alarming experience, and maybe you're at a heightened vulnerability of that at a point in your life when you're facing death.
Yeah, that's a good question. I think, you know, in sort of relation to these trials that have been conducted, a great amount of care is taken to prepare people for these experiences. You know, they have quite a few meetings with the therapist in question to sort of build up this rapport and this trust, and that's very important going into these sessions. And yeah, it's also like, obviously, yeah, great care needs to be taken for screening people to make sure that they are physically and mentally fit to sort of undergo something like this, even if they might be obviously really ill. But it's important to know that, yeah, something like psilocybin, while it is powerful, it's very, very non-toxic and physiologically well tolerated. So yeah, there's definitely sort of a case to be made that it's a more sort of yeah, it's quite safe physically to use, as long as the sort of more psychological aspects are sort of yeah, they're also safe and optimal. I guess. Sorry, slightly long-winded answer.
No, that's helpful. So we've got one or two comments and questions coming up. Jay in the I'm not sure if I'm saying it right, but Jay in the chat, condolences. His brother died this morning badly. So just making the comment that this is important stuff. There's a comment from Caroline Woodward, a question. What's the current state of play in the UK at the moment in regards to access to psychedelic therapy?
Well, the access to psychedelic therapy right now is very minimal here in the UK. It's it's extremely strictly kind of regulated, and the only legitimate above board psychedelic therapy trials happening are the clinical studies themselves. And so there's a phase 2 psilocybin major depression study that wrapped up at Imperial earlier in the year, just before the COVID lockdown. And so that's a sort of good move forward. There's no sort of psilocybin palliative care existential anxiety studies going on or planned, as far as I know. So it's very limited, and it's very tricky to do. It's a lot of bureaucracy, regulatory hurdles. It's very expensive, and because of the Schedule 1 status, the government should really be being more helpful and rescheduling it to Schedule 2 to allow clinicians, doctors, researchers to use it more easily. But I know some people will go to the Netherlands, and there's increasing kind of infrastructure there because psilocybin in truffle form, organic form, is legal. So some people go overseas for their psychedelic sessions.
Okay, so I think that comment, that question may well come up in the panel discussion a bit later on. So a couple more questions. I think we've probably got time for a couple more. Were the participants primed for a mystical experience?
So that's a good, yeah, I know Michelle. She's part of the Imperial team. So that's a good question. It seems that on the other side of the pond, that spirituality kind of comes into the psychedelic therapy model more, whereas here in the UK, we're quite a lot more secular and not as spiritual. So we're probably less likely to maybe prime the experiences here, but they certainly occur anyway. But it's an important thing that this, although, scientifically we kind of struggle with the idea or concept of spirituality sometimes, it is a key mediator here of the therapeutic benefits, the long-term therapeutic benefits, that when people have a mystical experience, the insights of that really stay with them. So it shouldn't definitely be neglected or overlooked in any way.
Okay, so I'm going to take one more question before we move on, which is from Karina Kamilov. What about the interaction with palliative medication? Does the patient have to come off their meds for a period of time before taking the psychedelic? And does that cause anxiety or increase pain putting them off? I mean, this is a key kind of implementation question, I guess.
So no, this is a good question, and something that will need to be considered. And this is more kind of like getting into pharmacology, which is kind of outside my area, to be honest. But there is a potential for interaction. It really depends on the drugs in question. So it would have to be like looked at by on a sort of drug by drug or compound by compound basis, I think, to sort of have a firm idea about potential interactions.
Well, maybe that's something we can ask some of the the folk who are actually running these trials in the group discussion, or because I suppose the key question here is about interactions and whether
Yes, I think
you know, do we know if psilocybin interacts with opiates, for example?
yeah. No, I
I don't know the
think, I
answer.
mean, as far as I know, there's not any direct kind of interaction through, you know, opiates and psilocybin. Like the opiates are likely to kind of mute or stunt the effects. So, and I think, you know, because great care is being taken over these trials being conducted. So I think people have to be off all drugs and medication for their psychedelic sessions, as far as I know. Yeah.
So, I mean, that I think we should probably wrap up there, but that, I guess, is a key. Yeah, it's one of those sort of nitty-gritty key issues which is going to kind of come into, if so you know, if we take these trials at face value and say that, you know, this is really hugely promising, and one was then to actually think about what the next steps would be. I mean, it'd be interesting to get different perspectives here. But, you know, as someone coming from a medical perspective, seeing this as a drug treatment, I would want to have the evidence of benefit in larger trials and be able to see the implementation actually working, and being able to then be able to say, well, actually, this is safe and effective, and we can roll it out. And when, in a way, to make that case for wider availability, one has to back it up with the evidence of safety and effectiveness in that kind of traditional way. But you know, apart from that issue you make about the kind of barriers in terms of setting up the trials, there's nothing else which should stop that from happening. And in a way, these effects are seen quite quickly, which means that you don't have to do such long trials as is often standard in mental health. And you know, that's a big advantage in people who are at the end of their lives, of course.
Yeah.
So, Sam, thank you very much. Really great introduction. And it's now my pleasure to introduce our second speaker, Ivor Williams. Ivor is at the Institute of Global Health at Imperial College London, and has I think it's fair to say, a sort of humane technology background. So he's established, I believe, a tech for good company, Humane Engineering, pioneering really user-friendly apps for mental health, and is now working in this field of palliative care and end of life. So, Ivor, the floor is yours.
Hello, can you hear me all right?
We can hear you, Ivor. Yeah.
I'll share my screen. Thank you
We
so
can't
much.
see you.
Yeah, I'm going to keep my video off because you're going to see the screen anyway. So thank you very much for the introduction. Yeah, so I'm going to bring, acting as a bit of a bridge, I'm going to bring some of my perspectives from the work that we do at the Institute of Global Health Innovation at Imperial. So I'll give a bit of background as to who I am, and I think outline some of the challenges, maybe issues you might want to call them, around a modern death, and just introduce some ideas, maybe some provocations around the use of psychedelics in palliative care. My background is as a designer, so I'm not an academic or a clinician. I'll use that as an excuse to speak broadly and in as much of a lay sense as possible. This as a topic actually came, I guess, came to kind of a bit of a fruition at one point. I think around 2014, my grandmother in Germany she phoned up my mom and said, "I'm dying, come and see me." And I was living in Italy at the time, and I was researching on lots of different things around death and dying. And I took with me on the train to Munich. I was living in Venice at the time. I took the train, and I took this with me. So Timothy Leary's Design for Dying. Super interesting book, and particularly pertinent for this kind of conversation. because what really struck with me afterwards was the missed opportunity that my grandmother had to heal at the end of life. She took all of her pain. She had a really hard life, and she took all that pain and frustration and bitterness with her, and it really left a mark on me as to, you know, the missed opportunities that people may have to heal at the end of life, and psychedelics being one way to do that, one doorway, made an impression on me many years ago. So I'll just introduce the Institute for a second. We're based at Imperial College, although we're actually physically situated at the St. Mary's Hospital campus over in Paddington. And we've been in existence since around 2012, 2013. And our goal at the Institute when it comes to end-of-life care is really to leverage our expertise in human-centered design, is what I specialize in, but also research, health policy, and economics to radically transform end-of-life care, both in the UK and globally. It's a new area that we've been developing over the last couple of years, and I'm very happy to be and very proud to be leading that work. But really, we're about creation and translation of research into co-developed and designed evidence-based solutions that really tackle both the human problems around end-of-life, but also the systemic problems. The work that we do is thematic in that the Institute has end-of-life care, also has areas around cybersecurity, patient safety, mental health, and the kind of work that we do cuts across different functions of design, data science, health economics, things like that. And we, you know, the way that we generate impact is through papers, but also through creating spin-outs and education and training, things like that. So if you've never heard of us, that's a bit of an overview. One of the interesting things around the work in terms of having innovation in our name is the type of innovations that we try and generate. And this is kind of I find a useful kind of simple way of describing the different types of innovation that you might have. If you were to think about how you might improve the healthcare system working inside the NHS, you know, that's one particular type of innovation. But what I find really interesting is if we are trying to disrupt outside organizations. So if we're working as an organization wanting to kind of work inside and kind of collaborate with other organizations, the kind of transformational change that we hope to try and achieve can be labeled as disruptive. But I really feel that there's lots of sliding scales on this kind of description of innovation, and in terms of psychedelics and palliative care, it does feel very transformational, and the opportunities are kind of very broad and really interesting. One example of the projects that we have developed over the last couple of years was around basically trying to put the patient back into the center of decision making in a clinical setting. And in particular, we were initially drawn to what they call do not attempt resuscitation forms in the NHS and in the healthcare service. And basically, we redesigned the way in which patients were making emergency care decisions. And it looks like a nice clean purple form like this, and it's called Respect. But really the interesting aspect was the way in which we as designers were involved in the redesign of a process, a clinical process, to see how people can really have their wishes and their priorities and their decisions respected in a way which it includes them into the process, which often the case can be sidelined or undermined by the pressures of delivering emergency care. So the work that we do and have done over the last 5 years has been around things like Respect, where we're redesigning emergency care processes, but we're also have done work around health economics. We've developed digital platforms to bring advanced care planning to the mainstream, and we've also worked around children's hospice care as well, prototyping new family-centered innovations. So the kind of work we do is broad. And that kind of gives you an idea of the kind of background of work that I've been doing the last 5 years or so. So I'll start by basically saying the work that, you know, the kind of starting point for me is to understand that a modern death, and I give the asterisks of pre-pandemic, because, you know, the effects of the pandemic, I think, are all, you know, could be fundamentally altering this kind of assertion. But let's just say before the pandemic, that a modern death, I felt, was really defined by this dichotomy, this tension between private pain and public ignorance. In the respect that the pain has been privatized or internalized, you know, 80% of patients with advanced cancer suffer distressing thoughts around death. As you might imagine, it's not necessarily a pathology, it's just what happens if you're having to deal with your death. 42% of end-of-life care services are inadequate and require improvement. It's quite a lot. Where we're talking about opiates and pain relief, 10% of people with cancer spend the last 2 days of their lives without adequate pain relief, which I think is far too much. It should be 0. But interestingly, 60 to 70% of people don't die where they would choose. And that's kind of the kind of internalization, or the kind of the way in which things have been kind of made to be ignored, and we become ignorant of them. And I think this is a really important point in terms of, if we think about, if we just take the assumption that we're talking about broadly the West, these are statistics from the UK, but you can also apply them to most other European countries. Certainly to America is comparable, that almost half of deaths occur in hospitals. 1 in 5 hospital beds are taken up by end-of-life care. Again, 60 to 70% of people die where they wouldn't, or dying, die where they choose. And although that's the case, the trend is changing. I don't think people appreciate how the trend is changing, that by 2040, 43% of deaths will be in a care home. So not in a hospital. They are declining over the years, but they're going to different places, and they're places where death is not an expertise in the same way. The interesting thing about hospital deaths is that 40% of people who die in hospitals don't need to be there for any treatment or medical condition. It kind of points to this problem that we have medicalized death to a huge degree, and that kind of has cascading effects, which I'll kind of get into. But another thing in terms of public ignorance is that most people don't recognize, understand, or really appreciate that just how much work family members, friends, neighbors, loved ones do at the end of life, where in fact 1/3 of the total cost of care at the end of life is contributed by informal carers. It costs thousands of pounds to care for a loved one when they die, when they're at the end of their life, and it's just a hidden cost. And so that really tells you something about the way in which death and dying and loss has been kind of hidden from us in many, many ways. And I think we look upon death and dying with a very clinical gaze in terms of the description that Michel Foucault uses to talk about the kind of piercing gaze of a doctor to look through your body to find your disease and to kind of assess you as a mechanistic machine. And that kind of, is symptomatic of the kind of, the medicalization, the kind of the separation of death and dying from normal life. And there's obviously loads and loads and loads of benefits of this in terms of being able to delay death through kind of interventions to provide really finessed and advanced kind of care. But nevertheless, there is a knock-on effect in terms of how we treat death and dying. Sometimes it can be viewed as failure. It can be seen as a sort of a bad result, when I think we can all appreciate that as a natural result. Because death and dying is, to use the description, of 4-dimensional experience, not simply a medical one. So this is from University of Edinburgh, and the 3 kind of archetypal disease trajectories that they outlined. There's 4 trajectories. So you have the physical element. So as you might imagine, so if you have time on one axis and function in terms of health along the other, you can see very different trajectories for cancer, organ failure like COPD, heart failure, lung failure, and frailty or cognitive decline like dementia, where someone might do very poorly for a long amount of time, whereas cancer, someone might be quite accelerated, very kind of declined very fast, and organ failure being a bit more of a roller coaster. But that's just only telling one side of the story. When you consider that the three other elements combine to really kind of tell you how someone is feeling, how they are, how they relate to the world as they're going through these physical changes, they're not the same, and they kind of vary very differently between the different types of diseases and conditions that you have. So to call it, simply a physical experience is really doing a disservice. I think we can all agree that's true, but it's really interesting to consider. Another element is that, I think I alluded to earlier, that death has been individualized, it has been atomized, it has been seen as a sort of personal experience that we all have to kind of go through, which is so odd because we all have to go through it. And so we kind of segregate those who are dying or those who are terminally ill from the rest of us, as if they're kind of, yes, they may have an infectious disease at some point, they may be kind of very close to death, but we're all on the same journey. And so it's a very kind of almost disturbing disassociation that we have, that we kind of make death a sort of very separate thing from the rest of our life. And I think this kind of detachment and kind of removal from understanding how things are connected is kind of at the heart of this kind of talk, I guess. The title itself comes from a kind of a riff on a statement that Fritjof Capra described around life. I describe it in terms of death. In terms of when we talk about death, we're talking about networks. Capra, who's a system theorist and a deep ecologist, refutes the kind of mechanistic Cartesian world model. And it really, I think, is really powerful, especially when thinking about end-of-life care and psychedelics in terms of the relationship to, say, psilocybin. The way in which we can understand the web and network of things, and the way in which things are interrelated, especially when it comes to death, I think is really important. So if we just take the view that for many people, death is unacknowledged, we deny it, we kind of don't talk about it, we kind of hide it under the rug. But the problem is that has lots of effects and has cascading kind of systemic issues around it, that if you don't acknowledge death, then it means we have decisions that are made late, or it might mean that we have less opportunities to reflect on our life, which then themselves mean that, if we have less time to discuss it, it means we have less time to reconcile it, which means that we can, have less time to resolve things. And if care decisions are made late, it has huge impacts on the healthcare system. I guess for me, like, we can extrapolate quite largely is that, it doesn't take long, in my view, to recognize the gap between, if we don't acknowledge death, you end up with Donald Trump in many ways. You end up with Brexit in many ways. The fact that death is so sidelined in our society that it has huge cascading effects. One of the reasons that I like to think about this is with the work of Bessel van der Kolk, when he talks about trauma, and this idea that trauma leaves an imprint, and that imprint has ongoing consequences for how the human organism manages to survive in the present. This idea that it changes us fundamentally. So when we think about the trauma of a bad death or a very sad death, the kind of effects it can have on people have cascading effects through their lives into passing on to generations beyond. And I think this is a really kind of one opportunity, one space for psychedelics to help shift the kind of the change for families and for people in general. So I'll elaborate on this. And in terms of describing how death, if we don't acknowledge death, we can kind of end up with Donald Trump. It might seem a bit of a joke, but the really interesting thing is if you read into the terror management theory, there's lots of evidence that shows that reminders of death can drive dysfunctional behavior, it can drive anxiety, and the way in which I think the authors of the terror management theory wrote in the early 2000s in particular, talk about the way in which, say, 9/11 in New York enabled and empowered George Bush, who was at that point the least popular president ever, to suddenly becoming the most popular president ever. could be rationalized through the effect of the death reminder of, you know, a huge atrocious terrorist attack in New York drove Americans to retreat into symbols of eternity, symbols of immortality, and the reminder that they were mortal terrified Americans deeply. And this idea that they resort to kind of what could be seen as dysfunctional behavior by the way in which they would enact incredible laws to really impede on their own liberty was quite incredible. So the question then of how can psychedelics change the way in which we talk about, engage with, and experience our own death, for me is a really, I mean, yes, it's such a powerful, interesting area. So this is my kind of perspective, and I use this as a bit of a provocation for the discussion. I hope we can kind of expand on this, and certainly as a layman here, this is my perspective on it. If we, you know, if the modern death is very medicalized, usually set in clinical settings and really kind of observed through this clinical gaze, my question is, how might psychedelics allow us to look at death and dying with a more natural gaze? How can psychedelics allow us to understand death as part of a natural process? I read last year, and if you haven't read it, I really recommend it, The Overstory by Richard Powers. And there's a moment in the book where a researcher is talking about the role of death in the forest. And the idea that the rotting log is home to orders of magnitude more living tissue than a living tree. That a dead tree is an infinite hotel, and how death adds value and rotting adds value to a forest. The idea that the relationship between death and life is not only kind of a cycle, but a virtuous cycle, a renewing positive cycle. And I think if we start to look at death and dying through this lens, we can really kind of shift the paradigms as to what our experience might be like. We're starting to see this a little bit in the kind of rise of the natural burial movement, particularly in the US, where the kind of preceding kind of history of embalming and very kind of chemically driven death practices, very industrial scale kind of practices, are being kind of shifted into treating the body as a organic composition, and allowing the normal processes of death and decay to be a part of the process of life. And I kind of wonder like how that could be taken further, especially in the care of the dying. So another question would be, how might psychedelics help us to see death as a continuum rather than an end? You know, extracting these timelines from earlier, and I think this alludes to some of the things that Sam was talking about just a moment ago. If we think back, you know, the question of why do we talk about death and dying? Why do we try and prepare for death and dying when we are actively dying or near the end of life or with a terminal diagnosis, is a real missed opportunity for us to really make the most of it. So the question of why cannot we, you know, think of the continuum of our life and actually act earlier, engage earlier, when the specter of mortality is not as pressing and not as fierce, I think would help enormously in terms of the experience of someone who might have to eventually succumb to a terminal disease. And I think this is really powerful when we then think about the role of the network and the role of the experience of other people, as I think the Tony Boss's kind of quote alludes to as well. This is really interesting in terms of the way in which grief experiences can palliate future grief experiences. The idea that lessons learned from one loss can activate existential changes in a person that provoke life pattern reformations, which can subsequently impact that person's grief reactions to loss in the future. So in short, how can the experience of grief actually help you with your own death in a positive way? And in this model, this ecological systems theory, which I think is a really powerful way of kind of mapping this kind of experience, if we place the person at the center of the healthcare experience, of the dying experience, this theory was actually originally started around children. This systems model sees this range and network of people, extending from a microsystem of the kind of people around you to the sort of the interactions and the environments that you might be around, extending outward and outward and outward to these macro systems of different mechanisms, all the way up to a kind of time-based system. But what I'm interested in is the way in which end-of-life care, the dying experience, can be made interconnected. So if one person is dying, how does the experience of them impact the patient, the person, their family, their neighbor, their healthcare professional, and how can those experiences be mediated, improved earlier in time through, say, the use of psychedelics or psychedelic therapy. I think this idea that if we just open ourselves to the idea that everyone is connected, the experience of the dying person has an impact on both the healthcare professionals, their friends, their neighbors, their colleagues, and that in turn, the more positive we can make that experience for the dying person, the more positive we can make it for everyone else when their own time comes. And then in that kind of respect, the analogy of the kind of mycelium network of the fungus in the forest, in relationship and interconnection with other natural systems, I think is a really fitting one, because on the surface they may seem like distinctively individual things, but dig deeper, you can start to see how everything is very tightly woven, very closely knit, and the positive impact that these can have to reinforce and to kind of support each other, I think is a really powerful, really beautiful metaphor for us to try and understand how palliative care, end-of-life care could be transformed through the use of psychedelics. And I'll close just with the same quote, because I think it's an absolutely astounding one, from the Johns Hopkins study participant that Sam mentioned as well. I think coming to this space from my position, there's obviously a lot to be done, but I do really firmly believe that there is so much opportunity to shift the paradigm as to not only how we treat the care of care for the dying person, but also how we even understand the relationship to death and dying and loss in a general sense as well through psychedelics. Thank you very much.
Thank you, Ivor. That was fascinating, beautifully presented. I'd really love that slide with death unacknowledged at the middle and leading out to Trump and Brexit and all those other things. And I kind of know where you're coming from, and I think this is there is so clinically, in terms of my own clinical practice, one of the things which always staggers me is the sort of sense which people with who get diagnosed, they might be in their 70s, 80s, 90s, can suddenly be so surprised by the fact of a terminal illness that this is, comes completely out of the blue, as though it's something really incredibly unexpected. And I think there's something you started off with a sort of caveat about the pandemic and what that might mean, but it is one of the things which I've been struck by in the pandemic about the kind of the surprise of death in even so, of course, the loss of people, the loss of loved ones in care homes, and some of the sort of management and issues and so on was a source of anger and upset. But there was something I think quite striking about the surprise that these often very frail people might actually die, which I think was quite striking and a difficult thing to say, because it's a difficult thing in the heat of all that kind of controversy about availability of PPE and all the rest of it. But it is remarkable. So death unacknowledged is certainly a really important theme. So let me just open up my chat box and see see what people have said. There's a couple of appreciative comments. Grief experience inoculating future grief experiences. I do think there is truth in that that model, that somehow one is. I'm an epidemiologist, and psychiatric epidemiology just shows that the more stresses and grief and troubles you have, it tends to lead to bad outcomes later down the line. But there are some people who clearly have these experiences, who have multiple adversities and somehow thrive despite that. So any other questions or comments? I'm aware of time, so there may not be time for many. Caroline saying, I wonder if COVID-19 will produce a major shift in consciousness amongst the masses. I wonder about that too. I suspect not. But Ivor, do you have a comment about that?
Well, it's interesting because some of the quotes there was taken from some work I did early in the pandemic around grief and collective grief, that was kind of exposing itself during COVID, which was taken from some other work I've done around climate grief. And so I think there is something to be said around the way in which consciousness is changing, of the idea. I don't know if you've got a background in epidemiology, but I think for most people, like, no one's ever really appreciated just how interconnected we actually are, because we've never considered ourselves vectors for anything. And suddenly we're being told that a sneeze in China causes thousands and thousands of deaths elsewhere in the world is kind of like never been made more clear to anyone. So I think there is something to that. But I'm particularly interested in the way in which some things can be rediscovered, and the consciousness raising, which has been lost in the modern world, that could be regained, is something I think is possible.
Indeed, I think that's absolutely right. So there's quite a lot in the chat, which is great, but I am aware of time, and we do have a discussion forum coming up, and it may be that we could extract one or two of those comments and insert them into the discussion a bit later. But again, I think you'd be hearing the ringing sound of applause if we were in a normal auditorium. And thank you very much, Ivor. So we need to move on now to our third and final speaker of this section, who is Oliver Bashford. And Oliver's a consultant psychiatrist who works with older adults in liaison psychiatry settings in the Surrey Partnership NHS Trust, but he's also the co-founder of the Maudsley Psychedelic Society, and therefore knows far more about psychedelics than I do. So Oliver, the floor is yours, if you can find a way to switch on your slides.
Thank you, Matthew. Yes, I'll share my screen. Okay, can you see my screen?
We can see you, but not your screen so far.
Okay, let me just try that again.
Yeah, something's happening now.
Is that better?
That's better. If you put it on full, yep, great.
Okay, so I'm going to be kind of building on Sam's talk, really, and talking about a bit more about what we know about the psychological mechanisms and the kind of subjective experience of the psychedelic state, and how it might help in this group of patients. My kind of interest in this stems partly from helping out in the psilocybin for depression trial at Imperial in 2015, which is the same year that we founded the Maudsley Society. So I've got some experience of working with it. So first of all, just to say, for those who don't know this, the meaning of the word psychedelic actually means mind manifesting. And this was coined by a psychiatrist called Humphrey Osmond. And when he sort of announced this, he described this term as being clear, euphonious, and uncontaminated by other associations. And of course, now the word psychedelic is very much contaminated by other associations with sort of kaleidoscopic imagery and a certain type of music and so forth. But at the time, it was a new term that he came up with. And it tells you something about perhaps what they thought might be going on in terms of this mind manifesting effect. And then the other thing I just wanted to say to kind of set the scene really is this sort of famous quote from a psychiatrist called Stanislav Grof, who described LSD as a non-specific amplifier of the unconscious. So again, something about bringing the unconscious into conscious awareness. This quote, I love this quote. This is from a very good documentary about the psilocybin for depression study called Magic Medicine. And one of the participants who did very well in the study, he says that he felt like he had swallowed a therapist. And that kind of captures quite a bit really of what I'm going to be talking about. So I'm going to say a little bit about psychological challenges associated with life-threatening illness. Then I'm going to talk a bit more about some of the historic examples of when psychedelics have been used in this setting. And then I'm going to go through the qualitative studies that have kind of followed on from a couple of the recent clinical trials. So first of all, just to talk about the psychological challenges that go along with life-threatening illness. So death anxiety or existential distress, I'll say a bit more about it on the next slide. But I also want to convey that, that it's not just death anxiety. And in fact, many of the kind of older patients that I see, often the reason that they're referred to me is because they feel like a burden to their families and they actually want to die. And so death anxiety is not always the main kind of issue. People may have significant regrets, they may be ruminating over, they may be in pain, or they may have a fear of pain, or other problematic symptoms such as nausea or breathlessness. Often people worry about those that will be left behind, particularly if they are carers themselves. There may be unresolved relationship problems, and I think there's some evidence that grief tends to be a smoother process if the relationship was positive compared to sort of negative. Many people struggle with the loss of role if they're unable to work, or if they lose their role within the family or as carers. Depending on the symptoms, there may be functional decline, so people lose their ability to do all the things that they used to be able to do. And many people find it very hard to adjust to the loss of independence. Maybe for a whole variety of reasons, a reduced ability to engage in activities once enjoyed, for example, fatigue. Some people, if they are depressed, may feel like a burden, particularly if they have high-level dependence needs. Those with pre-existing mental illness, the stress of this new diagnosis may kind of precipitate an exacerbation of something that was already there. And finally, just to mention the kind of 5 stages of adjusting to death proposed by Elizabeth Kubler-Ross. And this is a kind of model for trying to understand the process of resolving the sort of cognitive dissonance when you kind of go from through a transition of kind of denying death really to having an acceptance of it and sort of adjusting, going through that process. So just to sort of make the point again, it's not just about existential distress, there's all sorts of other things going on. Now a bit more about death anxiety and what it is. So looking through the literature on death anxiety, there's quite a lot from the world of cultural anthropology, world of religion, and the world of social psychology. There are various kind of theories about it. There has been speculation that perhaps much of human behavior, in terms of the evolution of social behavior, the development of religion, and in fact the development of human civilization, could in some way stem from an avoidance of the confrontation of death. In 1948, Melanie Klein, a famous psychotherapist, suggested that perhaps all anxiety can be traced back to death anxiety. There is this idea that death anxiety is somehow different to other forms of anxiety because it is a real event that is really going to happen. And in fact, it may be necessary for our survival. And so perhaps as living organisms, we have a kind of evolved a certain degree of death anxiety to help us survive. And so low levels may be adaptive. There's a lot of conflicting evidence in terms of risk factors relating to higher levels of death anxiety. Some studies suggest that men are more likely to have it, others suggest that women are more likely to have it. There is some evidence that firmly held religious beliefs of any form of religion may be protective. The crucial thing is how firmly the beliefs are held. there's some evidence that certain personality features, particularly humility, may be protected. So if you sort of take yourself a bit less seriously, you're less likely to have high levels of death anxiety. I think the evidence, from what I gather, is fairly strong that the peak levels of anxiety, death anxiety, are in middle age, in the 50s, and they reduce considerably into later life. There was an interesting study from Israel that suggested that the middle-aged children of elderly people their levels of death anxiety were a lot higher than their sort of aging parents, and that this could actually kind of interfere with the delivery of good care. One study actually found that there was another peak in the 20s. So young people, perhaps, and middle-aged people have the highest levels of death anxiety. It is a transdiagnostic construct, so it's not an ICD or DSM diagnosis in itself, and it's kind of associated with a range predominantly of anxiety disorders. So you're more likely to find it associated with generalized anxiety, panic disorder, OCD, adjustment disorders, hypochondriasis and so forth, as well as depression. And the sort of implication of that is that perhaps in designing treatments for an individual patient, we should be targeting kind of specific symptoms rather than the kind of diagnosis per se. There's a lot of debate about whether death anxiety, what it actually means, and if we're talking about fear of not existing anymore or fear of the process of dying. And there are various scales that have been devised to try to measure different aspects of death anxiety. And interestingly, I think only 2 of the 4 recent studies have actually looked at measures of death anxiety. And it certainly wasn't the primary outcome in any of them, and it wasn't the kind of inclusion criteria. So it wasn't like you had to have a certain level on your death anxiety score to be accepted into the study. The primary outcome measures were a lot more kind of general measures of depression and anxiety. So moving on from that, I just want to mention this paper because it was quite significant in the early years of psychedelics and palliative care. And this was I think he was an anesthetist called Eric Cast at the University of Chicago. And he's got this paper in which he was looking at LSD as an analgesic. And so he gets 50 gravely ill patients, the majority of whom had metastatic cancer, but 10 of whom actually had gangrene of the foot or leg. And he compared LSD with opioid analgesia, I think 2 different opioids, I believe. And LSD actually seemed to outperform the opioids, but it seemed to be some kind of psychological mechanism. He mentions this quote, which I like. So, in addition to pain relief, these patients displayed a peculiar disregard for the gravity of their situations and talked freely about their impending death with an affect considered inappropriate in our Western civilization, but most beneficial to their own psychic states. And when you read about the kind of setting of this study, it sounds as though it was a kind of like an open ward, that very little was done in terms of preparing patients. And interestingly, very few of them wanted to repeat the experience, but nonetheless, they had overall very good outcomes. Many, when asked whether they still had pain, they said that they did, but it was unimportant. And so they were no longer focusing on the pain quite so much. And so this was quite a significant study in terms of giving people the idea that perhaps they should look a bit more closely into this. This quote is from a study from 1973. And I think the story behind this is that this team in Baltimore were looking at psychedelics for predominantly addictions. And there was a member of staff who worked in the same center who knew about their research and had breast cancer and was struggling with this. And so they treated her, basically. And this quote, the reason I like it is because it captures quite a lot of the themes that I'm going to talk a bit more about in a moment. So I was alone in a timeless world with no boundaries. There was no atmosphere, no color, no imagery. Suddenly I recognized I was a moment in time. Again, in the void, alone, without the time-space boundaries, life reduced itself again and again to the least common denominator. I became poignantly aware that the core of life is love. At that moment, I felt I was reaching out to the world, to all people, but especially to those closest to me. I wept long for the wasted years, the search for identity in false places, the neglected opportunities, the emotional energy lost in basically meaningless pursuits. As I began to emerge, I felt joy. Later, as my family came, there was a closeness that seemed new. I was radiant, they said. I seemed at peace. So looking at the themes in this, this quote, there's reference to kind of transcendent, sort of transcendental experiences of ego dissolution, becoming nothing more than the moment in time, of sort of profound positive mood with this idea that the core of life is love. And then she talks about this emotional experience of weeping, going over the sort of negative experiences of the past, and emerging from that into a new position of feeling calm and radiant and having more positive relationships with her family. And these themes I'm going to talk a bit more about in regards to the more modern studies. And so this research group in Baltimore went on to do quite extensive research on this field. So these are the studies that have been done to date. There are 11, actually those 11 studies I think were predominantly in the 60s and 70s, and then 4 recent studies, which Sam mentioned in his talk. I'm going to talk a little bit more about them. So this is just a very brief and basic description of the types of patient who are included in these studies. And so in 3 of the studies only included people with cancer, the majority of whom had advanced stage cancer. It's worth saying that the sort of where they were in their kind of illness trajectory, it was highly variable. And so some of the participants had a diagnosis for many, many years, and others were more recently diagnosed. Some of them had a very short life expectancy following the study, and others lived for many years afterwards, or up until the current time. And so it's quite a sort of mixed group. In the study from Switzerland, they included one patient with Parkinson's, one with celiac, one with Behçet's, which I believe is ankylosing spondylitis. The actual diagnosis, in terms of DSM, the DSM diagnosis, it was predominantly adjustment disorders, essentially. So these are kind of and predominantly anxiety adjustment disorders with prominent anxiety. And so the implication being that there is significant anxiety related to the acute stress or the ongoing stress of the illness. The mean age was similar in all of them. They were around 50, approximately 50. So following on from 2 of these studies, the one in New York and the one in Switzerland, there were these qualitative studies that went on to interview some of the participants and try to get a bit more information really about the subjective experience and what the meaning that they attributed to their experience and what they thought were the significant subjective sort of effects of the experience. So this is what I'm going to be talking about now. So this is the Swiss study from Peter Gasser from 2014. And in this, they interviewed 9 out of 12 participants that were treated with 2 doses of LSD. Those in the placebo group had the chance to cross over and have the higher dose kind of a couple of months down the line. They used a technique called qualitative content analysis, and I'm not familiar with this technique, but essentially with this kind of research, what they're doing is transcribing interviews and pulling out themes and sort of categorizing them and trying to understand the themes that come up kind of time and again, really, and what are the key themes that come out of the conversations. So I'm not going to go through all the results, but I'm going to highlight kind of in line with the results that the authors themselves highlight. So the main one that they wish to emphasize is this theme: facilitated access to emotions and an emotional catharsis. So they described that a high proportion of participants described having a much more intense emotional experience than they would ordinarily feel they have access to, and that this was an important part of their process. So this quote, the LSD session set things free in my mind, which under normal conditions may not have appeared because they might have been suppressed. I mean, I did sense certain freeing moments for myself. I could let go of the weight of the fear. Well, I was surprised to find a real stirring of emotions, which I usually would not have felt with all my self-control and restraint. The second theme that they emphasize is what they describe as de-schematizing, or viewing experience, viewing yourself and the world in a different perspective. And they use a kind of analogy or metaphor of the camera lenses, and they say that many of the participants spoke about coming to see the world through like a wide-angled lens. So this quote sort of illustrates this point. I was able to put it into perspective, not to see one's sickness as center. There are more important things in life, the evolution of humankind, for example. Your inner ego gets diminished. And there were several other quotes that kind of highlight a similar kind of theme about seeing oneself as part of a kind of wider whole than had been seen prior to the experience. The next theme, they talk about a change in basic emotions. So this is contrasting with these kind of transient, intense emotion catharsis. Many of the participants described that, that in the first trip or at the beginning of the study, they had this kind of constant underlying anxiety. Some participants, the whole of the first trip was kind of characterized by negativity and anxiety, fear. But then later on, either in that trip or in the second trip, this sort of transformed, and they had a sense of a kind of underlying wellness, a change in their basic emotions. So this quote captures it. First trip was a panic trip with almost pure fear of death. It was agony. During the second trip, the dark side also showed up at the beginning, but for a rather short time. I was a little tense, sweating, but not for so long. Suddenly the phase of relaxation came. It became bright. Everything was light. It became a pleasant feeling, a warm feeling. And then in being asked about the longer term effects, quite a few of the participants described changes in perspectives, attitudes, and values. And when you read the descriptions of this, it's often kind of along the lines of they become less interested in material things, more interested in nature, in beauty, in music, and the kind of simple things. So I think right after the trip, certain changes happened, a shift in values, to make time to listen to music consciously. Maybe the material values were not that important anymore. Now, quite interestingly, in this study, the most important finding seemed to be this description of cathartic experiences. And although they don't actually give the sort of quantitative results, the authors say that many of the participants don't meet criteria for the mystical experience according to the mystical experience scale, which is developed in the USA. And in trying to explain this, the authors mentioned that there's a kind of historical divergence between European psychedelic therapy and American psychedelic therapy. So in Switzerland, in particular, the sort of model that was used was called psycholytic therapy, and this involved giving people kind of lower doses and having more interpersonal interaction. And the idea was that this process accelerate the sort of psychotherapeutic process. So psychodynamic interpersonal factors would be brought into the room, and that they would be the kind of the points of therapeutic intervention. And although they don't go into detail, they estimate that in the for the duration of the drug experiences, about 2/3 of that time was spent encouraging the participants to have a sort of introspective journey, but another third was spent kind of interacting. And I think that's probably more than in the American studies. So it might be something to do with the level of interaction. It might be something to do with the priming or with the kind of model and approach of the staff and the therapists involved. But it's interesting that there's this what is perhaps a bit of a kind of dogma about the importance of the mystical experience. But certainly for this group, they highlight that actually it's the emotional catharsis that seems to be the kind of central feature. Okay. There we are. Okay. So I'm having slight technical problems. Right. Okay, so at this point, Catherine, I don't know if you're able to take over the screen and set this video to 2:35. Is this a 1-minute video just to highlight this point about accessing emotions?
Feelings just came. And what it led to was a reawakening what it felt like when my first daughter, Tanya, died. And the feelings just came flooding out. I was completely into the strongest sense of despair and loss that I had after she died. And I howled. And I felt comforted that my guides won't come and comfort me. They won't stop me. They'll let me go into it. And I did. And that's sort of almost 30 years of not denial, but putting it down, suppressing how that felt. And that was very liberating. After that, the experience with the
Thank you. Okay, so moving on, I'm quite conscious of time. So the next qualitative study that I wanted to talk about was following 13 participants from the New York study. This study showed significant improvements in a wide range of measures, and 70% of the participants rated psilocybin as in the top 5 most personally significant experiences of their lives. And in this study, the score on the mystical experience scale did correlate with positive outcomes. And so this group were kind of emphasizing that actually they thought that the mystical experience was an important part of the process. But they did the qualitative research, try to dig into it a bit more and find out what the participants thought really. And so again, they did these semi-structured interviews, and they did a sort of thematic analysis of the themes in the transcriptions. These are the general themes. So 12 or 13 out of 13 cases described these. The top one, relational embeddedness. So they described this as a kind of paramount importance being given to the quality of interpersonal relationships. And in some cases, people would sort of have visions of loved ones. They would come to see loved ones in a slightly different light. And they would describe positive changes in their interpersonal relationships. And the actual the interviews themselves, the structure of the interview didn't ask about this, and so it was unprompted in all cases, this importance of interpersonal relationships. The next one was the range of emotions, and not just intensity, but the range of emotions. And some participants saying that they experienced all possible emotions and far greater range than they would ordinarily. Many of them, almost all of them, spoke about the importance of music, and we haven't really spoken about that, but it's part of the treatment is that there's a kind of soundtrack playing which has music designed to sort of facilitate cathartic experiences or perhaps mystical experiences. And so all these participants thought that was very important. Visual phenomena. So in addition to having kind of, sort of closed-eye hallucinations, people will have kind of visual memories, kind of there may have been forgotten memories emerging into consciousness, and or symbolic images coming into consciousness. And the majority of cases thought this visual phenomena was particularly important and meaningful. So-called wisdom lessons. When you read the description of this, they're talking about these kind of transcendental kind of insights into the nature of the universe. Revised life priorities. That's coming back to what I mentioned earlier about kind of becoming a bit less materialistic and more interested in the kind of simpler things in life, really. And 12 out of 13 of them said they wanted to repeat the experience, in contrast to Eric Cast's study in Chicago, where only a small minority wanted to. And it's probably something to do with the preparation, the care and attention given to kind of optimizing the environment, and so forth. Now, I'll just go through the next bit sort of fairly quickly, just so that we get to the end. I won't read all of these. These are the typical themes. So 7 to 11 out of the 13 cases describe these themes. You can kind of have a look at those. I mean, important ones too that they kind of highlight in their discussion. So embodiment, the importance of embodiment, and this is people describe this as kind of becoming more aware of their internal sensations and reaching a point of acceptance of their bodies, and kind of acknowledging that their bodies have cancer, and some of them describe visions of kind of expelling the cancer. Something about feeling more comfortable in their bodies was seen as very important. Transitioning from a feeling of separateness to a feeling of interconnectedness, again, that's very in keeping with the research done at Imperial with depression, the importance of connectedness. And these are some of the themes that came up in fewer cases. So synesthesia, interestingly, catharsis was less often reported here. Forgiveness came up a few times as well. And again, that comes back to the relational embeddedness. I think we're running out of time, so I'll skip. The last one was actually the same group of participants, but it was themes specifically relating to cancer, death, and healing. And again, it's all a similar kind of theme to do with sort of acceptance, reframing the situation, and kind of having a greater connection to the present moment and to life. And I think perhaps if we leave the last video, because I think it may slow down because of the technical difficulties. So in summary, these preliminary studies do suggest that measures of anxiety and depression can be improved and sustained with psychedelic-assisted psychotherapy for some patients with cancer or life-threatening illness. These are a highly select group, and the studies do have certain biases, but nonetheless, it certainly seems to be helpful for some patients. Meaningful elements of the experience are many and varied and include intense emotional catharsis, widened emotional range, relational embeddedness, altering frame of reference, and re-evaluation of values and attitudes, in addition to the mystical experience. So I suppose what I'm trying to say here is that it's perhaps not just about the mystical experience. And this should, of course, add to further work on the subject. And they are my references. So thank you for listening.
Thank you very much, Oliver. That's great. As you pointed out, we are at time, and there is 45 minutes for discussion from 8 to 8:15, but we planned to have a short break for people just to stretch their legs and a quick comfort break. So I suggest, I can see a lot of positive feedback on the chat, and really helpful sort of presentation on the literature as it stands. But I suggest maybe we save comments and further questions for Oliver to 8:15. Okay, it looks like we're back on air. Welcome everyone who's joined. I see there's 82 participants, which is fantastic, and gone up to 83, even better, which is great. It's an indication of the interest, because I think we started off with 100, and keeping people going beyond 8 p.m. is really terrific. I hope everyone got a quick cup of tea or whatever you did. I had a bowl of soup, which was very good. Okay, so we've got a time for a discussion now for 45 minutes. I know there have been some questions arising in the chat, but we've also got a couple of new speakers, as well as our existing speakers, to join this round table, as it were, a virtual round table. It's a kind of square oblong on my screen, but there you are. So what I'm going to do is ask the new members of the panel just to introduce themselves and say a little bit, maybe just reflect a tiny bit about what they've heard so far, just to kick us off. Can I start with you, Joe Bailey, from the Cicely Saunders Institute at King's College London?
Hi, thank you. So I'm a physiotherapist by background, and I worked in palliative care clinically in a hospice in Liverpool for just under 20 years, and recently completed my PhD at Cicely Saunders, looking at rehabilitation in palliative care. I think what's really interested me tonight, I think it might have been the second presentation. I'm so sorry, I've completely forgotten your name now. The whole idea of the natural gaze and not the medical gaze, and how the kind of innovative hospice movement that started in the 60s outside of the NHS how it did try to humanize medicine, and many hospices have horticultural therapies, music therapies, art therapies, whether they're provided by volunteers or paid staff. And I'm just wondering about the role of psychedelics as part of a spectrum of natural gaze medicine that's there for the proportion of people that do have this really severe existential anxiety, but whether there are other natural gaze type approaches that can be delivered earlier or provide a context for that therapy. And that's kind of what it's been making me think about tonight.
Very, very good point. And I think that is, we have heard a sort of a view of, you know, the very big challenge in providing good end of life care, but I still feel, you know, that the hospice I work in, you know, my predecessor as a psychiatrist there, Colin Murray Parkes, described the hospice as a therapeutic community, and it was, you know, very much in its heyday. I think driven by a lot of the ideas floating around in the 60s, which were to humanize, to really kind of challenge the medical orthodoxy. And I think, you know, the point also which has been made of you know, how bad it can be, that's true, but it also is the case that palliative care and that hospice sort of movement, you know, did come out of a situation which was even worse. And if you read, I mean, Elizabeth Kubler-Ross is often disparaged now as sort of, you know, these 5 stages of grief, and but it's a wonderful book on death and dying, and what it's wonderfully describes is the absolute abject isolation of people who not only were dying of cancer but didn't know that they were, or weren't able, no one was able to talk to them about it. And the hospice movement really did turn that round. So another part of the another member of the panel is James Rucker. James, I'm sure, is familiar with many people on the call as the other co-founder of the Maudsley Psychedelic Group. But James, do you want to say a little bit?
Sure, yeah. So I lead the Psychedelic Trials Group at King's College London, which I was able to set up because the NIHR, which is a UK government funded research organisation, granted me a 5-year fellowship to explore the safety and efficacy of psilocybin as a treatment for depression. So I'm in the curious position of being funded to challenge the government's own drug laws. But such paradoxes make for interesting research, and I'm very grateful for it. And I'm trying to do it in the right way. And for those of you who know the complexity and power of these drugs, you'll understand perhaps what I'm trying to say there. But I'm fascinated in the effect that these drugs have on consciousness and how they might be used therapeutically in situations like this. We've got a lot of work to do to engage with a process that general public and governments can understand. And even if we do engage with that process successfully, there is the problem of how to implement these treatments successfully in current healthcare models. But very happy to do it, and I'm very happy to be here tonight to speak to you.
And I hope a third new member of the panel is Shaheen Khan. Is Shaheen with us?
We can't hear you, Shaheen.
It's like a bit like a seance. We're sort of calling into the void and hoping to get a response.
I think he's having technical
Shaheen,
his microphone. So
he's having technical difficulties. Okay. Now, just wait a moment longer. Okay. Well, what I suggest we do is, Shaheen, if you get past your technical problem, just butt in. But what I think we should do now is encourage some live questions, and I think on the chat it's mentioned that you can just. I'm not sure quite how we're going to curate this, and if it gets if there are too many questions all at once, I'll have to start being start trying to do it some different way. But you can now, I think, speak on, turn on your mic and ask a question. And perhaps if you do so, just introduce yourself. We've got one or two up our sleeves, but I'd like to hear from the audience as
and
well.
I'm not sure if you can hear me
Oh,
yet,
brilliant.
Matthew.
Shaheen,
Great.
welcome. Great.
Apologies, made the I think it's at least a weekly error of putting myself on mute in the new world that we live in. So thanks for having me along. Fantastic talks earlier today. Thank you to the three speakers. My name's Shaheen Khan. I'm a palliative care consultant. I work at Guy's and St Thomas's, and I see patients in the community, clinic and hospital settings. Work closely with Joe and lots of colleagues at KCH and KCL through my role as joint lead for the palliative care clinical academic group at King's Health Partners. And I can see some colleagues on the call as well. So really interested in the ideas around potentially building the evidence base gradually to progress towards having something that we can use clinically. I think I find myself in an unusual position often as a doctor who specializes in supporting dying people who's actually trying to demedicalize death at times. Ivor, I think, talked about how people take their pain with them through life and into death. And Dame Cicely coined many things, including the concept of total pain. And unfortunately, we still see quite a lot of people having what you might regard as psychological pain or existential distress being treated medically, and often treated in the wrong way with strong analgesics, for example, where what they actually need is focused support on their psychological and psychiatric well-being. And we're still working to overcome this myth that people only die when doctors and nurses stop treating them. Matthew, you mentioned, I think at the start, that we already use lots of very powerful drugs in palliative care, including opioids, but also things like ketamine and amphetamines. I'm quite excited by what I'm learning about psilocybin in terms of the lack of toxicity and the non-addictive properties that it seems to offer. But I think, as with most of us, I think we'll come away from this talk really excited, but also probably more aware of the barriers to using this. So I think I'd be really keen to hear what people have to say about the potential for some sort of collaborative group to look at how we can work, I guess, across KHP, Imperial and all the teams here, but also learn from colleagues abroad. And we'll look to James to lead the charge against the government, I think.
Very good. Okay, so there is a question which is on the chat, which is quite close, I think, to the some of the things which James has been saying. It was about from Jamie about, do you think there'll be a trial of psilocybin in the UK? I presume you mean a trial of psilocybin in this context. And Jamie, hi. Do you want to speak?
Yeah. So I'm an oncologist based in Nottingham, and I just wonder whether it's perceived that it would be useful for the regulatory authorities to have a UK-based trial, or whether, as in most other drugs, when it's licensed, presumably off the back of the trials for depression, we'll be able to prescribe it off-label, as we are in many other drugs. And it's just about how best to approach those perception barriers from the regulators. That's what I'm curious about.
Okay, who on the panel would like to pick that up? James, you're on the top of left of my screen, so I can see you nodding, and you're inviting a...
Yeah, so it's a complex one. It's harder to do trials in palliative care in people with multiple medical morbidity because there are so many other factors at play, so it makes for a more complex trial and thus a more expensive trial. Nonetheless, I'd like to do one in exactly this area, and we have everything we need to do them here at King's. I mean, we have the drug and the Home Office licenses and the research team and the therapists and the hospital with the patients. We don't have the money for such a trial at the moment, but if some is forthcoming, I would be very happy to lead on that. So and I think particularly because of the nature of psychedelics, I think they're quite a special case when it comes to exactly this sort of scenario, and because of their relative lack of physiological toxicity, and they really are, pretty non-toxic drugs. I do not have a concern when I sign a prescription for psilocybin the same way as I do when I sign a prescription for olanzapine or something like that, and yet I give olanzapine out for people to take home and take every day. So the answer to your question is, I think there is room for a trial here. I'd like to do one. We don't have the money yet, but I think it would be of regulatory interest, actually.
I think that's a great answer. Anyone else from the panel wanted to come in on that?
I'll just add in really. I guess in palliative care we're comfortable where we need to using medications off-label, but clearly, if we have an opportunity to build that evidence base from scratch, it would be fantastic.
There's a question here from someone whose name is Idadoff, who asks about selection, and that was something I was really interested in knowing about. I don't know if you want to come in live, or if you don't come in live, I'll read your question.
Yes, hello, good evening. Thank you for this evening. I would like to ask, as I wrote, what are the characteristics of patients that agreed to participate in this research, because we know it's not people like us that are interested in this field. Those are people with a lot of, they are naive in the psychedelics issue. So how people that were choosing, patients that were choose, what are the characteristics, please? Thank you.
So maybe I could ask Oliver or Sam, who presented some of that literature, to say a bit about that. And
yeah, I mean, shall I comment? I think that I think the selection process or the recruitment process was sort of based upon posters and flyers and adverts and so forth. So I think people were kind of putting themselves forward for it, if you like, and so that adds a layer of kind of selection bias in terms of the sorts of people who would be drawn to those posters, and those leaflets and so forth. In terms of the actual characteristics of the participants, I think it varies a little bit from the studies. I mean, the one that I've kind of got in front of me now is the New York one, and in that one, so for example, 46% of the participants had prior hallucinogen use. This is the qualitative study, and I think it was a similar kind of proportion for the main study itself. So nearly half of people had taken psychedelics in the past, so that's more than the general population. I think they're, in this particular sample, so about 40% of them are atheist or agnostic. 30% of them had graduated 4-year college. So, they're perhaps sort of slightly more likely to have a sort of higher education and plus prior sort of hallucinogen use. But I think they're a self-selecting group. I mean, that's a crucial thing, really. I think people are putting themselves forward for this.
So can I just follow up on that? Because it may be physically a very safe drug, but I suppose one of the things which came across in your presentation was not everyone has a completely smooth journey. There are some people who have a bad trip, and these are people, as you say, who've been selected on the basis of, well, they're sort of self-selected, right? So I guess the question then is, in other contexts where psilocybin is being used, in the treatment-resistant studies or treatment-resistant depression studies, for example, what checks do you put in terms of the eligibility and whether someone gets the drug? How many people do you actually end up turning down because they look, they seem in some way unsuited to it, and how do you make that decision?
I mean, I think my understanding is that there are certain kind of clear-cut criteria in terms of history of psychosis, I think first-degree relative with psychosis and bipolar disorder, suicide attempts, and so forth. But that more kind of the question about sort of subtle, something about the personality, something about the defense mechanisms, or their that thing that's a bit harder to describe. I'm not sure exactly how they kind of capture that. I don't know if James could comment on how there's sort of clause that allows some discretion about selection.
Yeah, so because these drugs put people into an emotionally sensitive state, we have to be sure that we have formed a rapport, a trusting rapport with someone before we randomize them to receive different doses of psilocybin. So there is a clause in studies which basically says that if we don't think you're ready and we don't feel we can form a rapport with you, then we reserve the right to withdraw you. So that provides a sort of catch-all scenario for trying to avoid what we think is probably the main driver of a bad trip, which is feeling unsafe in the first place. And the reason why you might feel unsafe is because you don't trust the people who are with you. So there's a sort of chicken and egg element to this. Whatever treatment you look at, probably in medicine, but certainly in psychiatry, patients self-select. So, there are always going to be some patients who would never consider psychedelic therapy, in the same way that there are some patients who would never consider antidepressants or lithium or anything like that. Is it a reason not to do the research? I think probably not. Does it bias the research? Probably. In fact, definitely. But as I say, I think it's a sort of more generalized issue. And I think we have to recognize the fact that in healthcare, patients select treatments, and they do that because of prior conceptions. And that's okay, because there is a psychological element to all treatments. And Mike Jay, the historian who wrote a great book on mescaline, he describes psychedelics as super placebos. And I think it's quite a reasonable way of thinking about them, insofar as they appear to make people very sensitive to suggestion and context. But that mechanism is itself clearly mediated by something biological. We know that they're serotonergic agonists, and so it is interesting. And of course, medicine has always capitalized on the placebo effect, and we continue to do so today.
Ivor, did you want to come in?
Me?
Only if you wanted to. I saw you suddenly pop up. I wondered if you were.
No. I'm just
okay.
Not comment for me.
Okay, great. So this is quite a medical conversation so far in terms of licensing and harms and all the rest of it. I don't know, and there's a chat going on in the chat about ketamine and its use in palliative care for depression and so on. I certainly was trying to set up a ketamine study a little while ago, actually, and we were turned down for funding, and it felt like the palliative care field had sort of got rather shy of ketamine as a painkiller because of the because of a large-ish study which showed a lot of neuropsychiatric complications of it, but not, to my knowledge, not having been formally tested in trials in depression. Ongoing trial and treatment of resistant depression, ketamine, yes, absolutely. So there's a ketamine thing. Jobe, can I ask a question? Please do.
Yeah, I'm just interested in what's been the thread in quite a few of the talks about the rapport and the preparation for people who are going to try psilocybins. And I'm just wondering, being as a lot of palliative care settings already have, not all, but many do have quite well established psychological staff within teams who are already talking about existential death and dying issues, would that not make the UK palliative care setting the most excellent place to deliver these trials without that huge extra resource, because they're already in place? It'd be repurposing the staff who are delivering perhaps less effective psychological therapies now.
Yeah, I couldn't agree with you more. The problem comes with Schedule 1 and the licensing, but there are ways around that.
Good. So there's a comment from Annabelle on dying well. I don't know, Annabelle, if you want to come in and raise that question.
You're muted.
Oh, I'm muted. Hang on. Can you hear me now?
Yep.
Yeah, it just struck me, you know, the focus is obviously dying well, but surely a lot of these benefits could help people live well. So any comments about that?
So really taking this outside of a kind of, I mean, I suppose the question is, normally we prescribe, you get a license for prescribing drugs on the basis of a treatment of a medical condition, and I guess what your point is hinting at is a sort of broader, you know, a broader enhancement to health, which these the psychedelics could actually provide. Maybe I could ask Sam or Ivor to pick up on that.
Yeah, sure. Yeah, just quickly, I think it's a very good question, and sort of, yeah, just to quote Roland Griffiths, who's kind of like led the charge to some degree with revamping psilocybin research in the US, and has played a pivotal part in this. And he's quite, you know, he's a meticulous, well-regarded scientist, and, you know, very data-centric, and sort of doesn't go out on a limb really. But he was kind of interviewed, and at the end of the interview, the interviewer kind of asked him, you know, what about, you know, the future, the bigger picture? And he kind of shuffled in his chair a little bit, sort of uncomfortably, and said, you know, we're all terminal. We're all dealing with death. This will be far too valuable to limit to sick people. And yeah, just, you know, alluding to the Stan Grof quote that I sort of kicked off my talk with about dying before dying. And I do really think that, yeah, having a simulated dying, or a dying before dying experience, can bring in a sense of levity and perspective on one's life and the priorities of one's life, you know. And in the same way that, you know, you hear insights from people on their deathbed about aspects of life they wish they hadn't worked so hard, is perhaps the most common one. I wish I'd made more time for loved ones and family. And there's huge wisdom, I think, that can come from people who are sort of on that event horizon. So yeah, the short answer is yes. I think like the perspectives that can be potentially obtained through this experience, they very much could extrapolate onto one's life before they reach the end of it. But sort of, yeah, that I guess is a controversial view to hold, because these are highly illegal substances in this part of the world.
So,
one more.
Okay, Annabelle, I'm going to ask Dan to come in next, but Annabelle,
just a quick one.
Follow up.
I know that you exclude people with bipolar and psychosis, but in some cultures they would be given psychoactive substances, would they not? And do you think it would ever be possible for people with bipolar, for example, to have this treatment?
James, do you want to take that? Or Oliver?
Yes. Sorry, just fiddling with my mute button. The short answer is yes, it's possible, but first we have to get our foot in the door. And I think the problem, I mean, at events like this, we're kind of preaching to the converted, and it can turn into a bit of an echo chamber. But ultimately, there's an awful lot of people out there who are dead set against psychedelics because they believe them to be bad. The only way I really can see to challenge that is making a health-related argument. And to make a health-related argument, I think, are sensible to avoid those areas for the time being and concentrate on the things that there is historical evidence for. And of course, sadly, the evidence with LSD and mescaline, when they were tried on people with schizophrenia, is they made them worse. Sometimes people benefited, but most of the time they were made worse. The issue with bipolar disorder is slightly trickier. So much bipolar disorder, I think, is rooted in trauma, and for those sorts of people, I think there may be great therapeutic utility, but you've also got people with functional sort of type 1 bipolar, and for them, I fear probably not. So a slightly trickier area to engage with. And as I say, I think it's sensible for us to try and get our foot in the door with things like depression anxiety and addiction.
So, thank you. Dan has been waiting very patiently, wanted to ask a question.
So patiently. Thank you for this great panel. It's a joy to listen. So I work for Synthesis as a lead facilitator and director of ethics, and sometimes people reach out to us as well. And we currently are in no state to offer the type of support that you would want to give people who are dying. But one other question that we've been contemplating from a more medical ethical perspective is, how do you mitigate some of the risks associated with the potential that someone has a very difficult and challenging experience and might be so close to the end of their life that they're either unwilling or incapable of integrating that well, hence potentially contributing to actually dying worse rather than dying well. And I think the context for that is that we've seen that sometimes, despite tremendous effort to really prepare people well, build a thorough therapeutic alliance, do very quite rigorous medical health screening, we still see people that come with such a level of desperation or expectation about the effects of psychedelic medicine that we simply cannot, either the medicine or us or the combination of the setting, the drug and the setting, can just not deliver that. So I was wondering if any of you could speak to that, and maybe if there's differences then in the psycholytic or psychedelic approaches, or if you use multiple experiences. Yeah, maybe you can speak to that. Thank you.
So it's this old question, I guess, of, I mean, put bluntly, about balancing risks and benefits, and you don't know until you test, would be my kind of maybe rather reductionist response to that. But others on the panel want to pick up on that?
I mean, I guess I could make a comment that one of the things that they make in the Swiss paper is that there's this kind of idea circulating that that the material that emerges into consciousness will only be that which you can cope with, basically. There's this kind of idea that you're left to its own devices, and with the right support, your mind will kind of heal itself, and it won't bring things into consciousness that will be overwhelming or that you won't be able to handle. But I think that's probably not evidence based, and you can't really rely on that. From these studies, they said there weren't any serious adverse psychological reactions. They had mild adverse psychological reactions, but nothing serious. But of course, it is a highly select group of patients, and from your experience, there are people who are very desperate and who actually could have a really difficult experience that they can't integrate, or maybe they need time to integrate and they don't have that time ahead of them. So I don't think there's an easy answer to it, to be honest. I mean, I guess in future, perhaps, if there is exploration with different doses, and if there's a kind of, if there is development of the psycholytic approach using lower doses and a more kind of more traditional sort of psychotherapy approach, perhaps that would be kind of safer if you are concerned about kind of overwhelming experiences and not going to be able to be integrated.
Yeah, I think, I mean, it does seem to me that, this is, I suppose we're elevating this kind of concern to a different type of adverse drug reaction, as you'd call it, in a sort of trial setting, and yet we tolerate all sorts of really awful adverse drug reactions in mainstream practice. I mean, I'm constantly seeing people, well, not constantly, but often seeing people on opiates who are having all sorts of, unpleasant sensory perceptions and so on, and they've got opiate toxicity. Well, maybe that's something which is reversible and they feel better from, but actually, you give someone a sort of delirious state, and they often remember it, and it's quite alarming. So I think we do that already in medicine to quite a large extent, but so I'm getting distracted by the sort of crosstalk here. So there was a comment. Whoa, hang on, sorry. There was a comment about, I think, an interesting comment about bereavement and loss. Was that Karina? Because I suppose when the question came up about living well and normalizing. I suppose what I was thinking was that actually the other side of the coin in palliative care, and certainly the other side of the coin in the palliative care psychiatry I do, is seeing people who have had a bereavement. And most people who have bereavements, it's a painful experience, but it's something which people get through. But sometimes I see people, I get involved when people are incredibly stuck. And I can say that the group of people who are incredibly stuck, in my whole career as a psychiatrist, having seen some very disturbed people with kind of schizophrenia or bipolar disorder at the height of their kind of relapse, the group of people who are stuck with intense bereavement, sort of abnormal grief reactions, whatever you want to call it, are some of the most harrowing experiences to sit through. They are reliving and re-experiencing the worst. Sometimes it's a sort of PTSD-ish type of experience with it, but sometimes it just feels incredibly stuck and incredibly difficult to sit through. And as the psychiatrist, so I suppose I am quite interested in that angle about whether the panel thinks there is an interest in using. I sort of I suppose I know the answer that people might give, but it does seem to be an opportunity that actually this group of people might benefit and might help some in some very crude way, some sort of unlock something which is very harrowing.
Yeah, so we've been considering this. We've actually been writing a protocol about traumatic loss and complex traumatic loss, and the problem is how you define it in a way that's compatible with the protocol and with regulatory processes and all the rest of it. But I completely agree that is exactly the sort of area where these drugs and this sort of therapy may have real benefit, is complex traumatic loss that has become very fixed and people have become very stuck with. And we know that the drugs loosen these patterns of thinking, and within a safe and supportive context, that may be where the therapeutic window of opportunity lies.
Yeah, just to say quickly, just to highlight some research that's been done on ayahuasca and grief processing, and it was a prospective observational study, so I think the first of its kind, but it found that acceptance, ayahuasca sessions sort of promoted acceptance and decentering as mechanisms which helped with grief processing. And interestingly, quite a high number of people actually encountered the deceased essence of whoever it was they were grieving for in the ayahuasca session. And obviously, the ontological basis of that is a whole other sort of talk. But irrespective of it being real or an illusion, it sort of interfacing with what was perceived to be that was immensely therapeutic for people. There's a really interesting story of a guy who survived the Nazis and in the Second World War and came to the States and made his millions actually, but his dad got taken off to a Nazi camp without saying goodbye, and for 70 years he'd had a depression ever since then. And at the bidding of his friend, and much to his reluctance, he went down to Mexico to drink ayahuasca. And on his second ayahuasca experience, he sort of met his father, and his father told him why he didn't say goodbye, because he just thought, I'd be back really soon. I thought I could kind of wiggle or charm my way out of the situation. And that fit with what he knew of his dad. And even 70 years on, his lifelong depression that he'd had since that time evaporated. So it shows how deeply affecting these experiences can potentially be. But very largely unexplored.
Great. I think we probably only have time for one more question. And I'm trying to find out, I thought I had one and I've lost my train because something distracted me, but there was a question. I mean, there was a question I think which is really a question about culture, basically, which Katie raised. Katie, do you want to speak?
Hi everyone. I just noted from Sam's talk that there's some like legal medical exceptions being made for using psilocybin in end-of-life care, and there's a trial ongoing in Australia. And I was just interested in hearing about your views about what you think the main barriers are in the UK, because obviously there's the legality issues and funding and licensing for the research is challenging. But I was just wondering if you think there may be a cultural element at all to the barriers in the UK.
So are we more conservative than other? I mean, let's stay with sort of industrialized Western societies, but are we more? I mean, what happens in Europe, for example? Is there much of a? I mean, we heard about a Swiss study, I think.
What to say? Yeah, well, the Swiss have always had an interesting attitude towards psychedelics. Of course, Hoffman was Swiss, and Sandoz, the pharma company that marketed LSD and psilocybin, was Swiss, I think. And Peter Gasser, who we heard referred to in Ollie's talk, is, I think, pretty much the only psychiatrist in the world who has essentially a special dispensation from his government to prescribe LSD to people on a compassionate basis, and he does so. But Switzerland's a special case, and aside from that, and the Netherlands, of course, which has where you can legally access psilocybin-containing truffles, the rest of Europe is pretty conservative, and I would say overall that the UK is not that conservative. I mean, we are conservative, but not that conservative relative to everyone else, and that's simply because we are doing the research, and the Home Office are engaging with the applications for licenses to research the drug, and that is completely up to them. It's within their power to just say no, and they did, I think, for many years. So there's been a slow shift, and that shift reflects the fact that I now have UK government funding. Compass Pathways is now producing psilocybin to pharmaceutical standard. Compass is a UK pathway, a UK company. So in a funny way, no, I don't think the UK in a sense is leading the way in many ways, but there is still a huge amount of conservatism about this drug. Perhaps conservatism is the wrong word. To get over.
Absolutely. So I think that's a good point, probably to wrap up the discussion. An optimistic point, perhaps, that within within certain parameters, there's going to there may be a cautious relaxation of our ability to study the medicine. I mean, I suppose. It's it does seem to me that in order to make it widely available, assuming it is effective and safe, and particularly if it was as effective and as safe as we've heard, there is just that route is kind of necessary, because I don't see the alternative of a kind of complete relaxation to the point of legalization and recreational and sort of medical shamanic use being widely being likely. So this is the best approach, I guess, the most likely approach to make something beneficial widely available. I'm going to stop there and say my thanks to the organisers for inviting me to chair and listen in on this really fascinating discussion. And I'm going to hand over to James as the chair of the Maudsley Psychedelic Group to just wrap up.
Yeah, thank you, Matthew, and thank you so much for chairing. It's really through your calm and wise tutelage that brings the sort of equipoise that I think the field needs. I want to hugely thank the people who've organised this event. Gemini and Rosie Ellis spearheaded this effort, and it's taken, I think, about a year and 6 months to get this event happening tonight. And it's come at a really nice time, because we are recommencing our psilocybin dosings tomorrow morning after the 6-month hiatus caused by COVID. So yes, huge thanks to Gemma and Rosie for organising all this, and huge thanks to Catherine Bird, who has organised the technical support for tonight. Thank you very much to our wonderful speakers, Sam, Gandhi, Ivor Williams, Ollie Bashford, Joe Bailey, Shaheen Khan. And I'd just like to thank Alan Young as well, who's not here tonight. He's the chair of mood disorders at King's College London, and he's also my boss. And he supported me unflinchingly and wisely as I set this all up and acquire the funding from the NIHR that's allowed us to bring this event to you tonight. I think I'll just end with a quote from the Tibetan Book of Living and Dying. It says, a human being is part of a whole, called by us the universe, a part limited in time and space. He experiences himself, his thoughts and feelings, as something separated from the rest, a kind of optical delusion of his consciousness. This delusion is a kind of prison for us, restricting us to our personal desires and to affection for a few persons nearest us. Our task must be to free ourselves from this prison by widening our circles of compassion to embrace all living creatures and the whole of nature. And I think to that I would add death as well, which of course is a part of nature and a part of life. So many thanks to you for coming to this event. Just to say that the money from this event goes back into the research. So by supporting us, you are supporting the research as well, and the participants in our trials. And yeah, that's it for this evening. We're spot on time, which is wonderful. Thank you so much.